Yes. Well, thank you everyone for tuning in to this Instagram Live with myself, Dr. Garen Wolf. I'm an allergist immunologist, and Dr. Fenwa Millhouse, board certified urologist. And the title of this Instagram is Chronic Cough and Pelvic Floor Disorders. And I have to be very honest, I did not know there was an association between the two. Now, as I think about it, it makes sense, but it wasn't on my radar. And I'm really happy that Dr. Millhouse brought this to my attention because I see chronic cough on a weekly basis. And since she told me about this association, I have now let my patients know, especially my female patients, hey, out to the ladies out there, know about the association and that it needs to be diagnosed and treated. And if they do show signs of pelvic floor disorders, I know exactly the wonderful person to send them to. So I really appreciate her bringing this to my attention. So we'll start with introductions. Dr. Millhouse will talk about briefly what she does as a urologist, where she's located, and what maybe one of her favorite things about being a urologist is.
So I am Dr. Fenwa Millhouse, your favorite urologist. I'm board certified, fellowship trained urologist. I have a special subspecialty in pelvic floor and urogenital reconstruction. I treat men. I treat all vulvas and penises, okay, that have the gamut of urologic problems. And I am out in the Chicago suburbs, and I am like the main pelvic floor surgeon for my current practice. I love, 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 love what I do. And I love talking about what I do, and I love sharing and teaching and educating patients and other people and getting other people excited about what I do. So, yeah, that's me. Hey,
Well, thank
Bree.
you for
That's my
that.
nurse, Bree, that just joined. Hey,
Oh.
Bree.
Hi. Well, I'm board certified internal medicine physician, so I'm internal medicine trained. For allergy immunology, you can be internal medicine trained, pediatric trained, or med peds trained. So my background is internal medicine. Allergy immunology is the only internal medicine subspecialty that treats both adults and kids. So I am treating children, which was the first time I've had to do this, which has been great and very interesting. Allergy immunology encompasses allergic disorders such as asthma. Asthma can be allergic and non-allergic. Atopic dermatitis, which is our huge word for eczema. Hives, food allergies as well, as along with environmental allergies. And also we look at disorders of the immune system. So many people don't really know that allergist immunologists exist. And thanks to Dr. Fauci, he is an allergist immunologist. In fact, when he trained at the National Institute of Health, he triple boarded. So he's internal medicine, allergy, immunology, and infectious disease.
Yeah, I didn't know he was allergy and immunology. I thought he was
Yeah.
straight infectious disease. Okay.
No, yeah, he was. So when he trained, infectious disease was incorporated into that. And so anyway, so we deal with diseases of the immune system as well. So recurrent infections, genetic diseases that lead to recurrent infections. My favorite part about being an allergist immunologist, well, I love treating asthma. Asthma disproportionately affects minority populations, specifically Black, African American, Latino, and Native American. And so being an African American myself, I really like having a practice, Wolf Allergy and Asthma, that can provide culturally competent care. And so that's one aspect, is the fact that I can kind of give back. And the second, I just really like asthma. And I like when patients find relief after being appropriately treated. And so that to me is very gratifying. So, oh, and I'm located in Detroit, Michigan. Yeah.
And you own your own practice. Is that correct?
That is correct. Yes, I opened my practice. It's Wolf Allergy Asthma located.
Y'all better heart that. I want to see hearts up in the air. That's huge.
Yes.
So sorry, go ahead.
So I started my own practice, and it's in the Fisher Building, which houses the world famous Fisher Theater, and it's been an adventure so far. So,
That's wonderful.
yeah.
Wonderful. I see
So,
some people have to shout out to Dr. Camila. Thank you for joining, Soul Sister. I
yes,
see
I
you.
know Soul Sister.
So feel free to shout out to anybody you recognize,
Okay, for
Dr.
sure.
Wolf.
For sure. I know Soul Sister and I know Bella. Those
Yeah,
two I saw in the chat.
awesome.
So, what is the goal for tonight? The goal is for those who are watching and for those who catch this on the replay to, number one, be able to recognize chronic cough syndromes, pelvic floor disorders, and to really know the importance of getting chronic cough diagnosed and treated and who to go to for that. So that's kind of
Yeah.
the goal. I'll start off with chronic cough, what exactly chronic cough is, and then I will pass it off to Dr. Millhouse to talk about pelvic floor disorders and how there's the connection. So, what's chronic cough? Well, cough is a symptom that most people have experienced sometime in their life. Chronic cough is defined as a cough that lasts for 6 weeks or greater. And there are five main causes of chronic cough. So when I see patients, and honestly, Dr. Millhouse, I see patients every week for a chronic cough. So when I see patients and they say, Dr. Wolf, how do I get this under control? I tell them there are five causes. And sometimes you can have a combination of those five. So chronic cough is not as easy
As I
to
cough,
treat.
sorry.
Oh, yeah,
Go ahead.
exactly.
Sorry.
Very timely.
Yes.
Chronic cough is not as easy to treat and manage. So the first cause of chronic cough is chronic bronchitis. We already know what chronic stands for, which is long-standing. So what does bronchitis mean? Well, bronch stands for bronchioles. So everyone's lungs have these little branches that are called bronchioles, and itis means inflammation. So bronchitis is inflammation of your bronchioles. What causes that? Well, irritants. So fumes, like chemical fumes, cleaning products, working in a factory, dust, and then smoke,
I think is what's
whether
going
that
on
is,
around me.
oh no, you're fine. You're fine.
Keep
Whether that,
going. But I
whether
might need
that's,
your services.
no, you're fine. Well, you know where to locate me.
Yes.
Um, so yeah, so that's smoke, and that could be vaping, that could be tobacco smoke, that could be roasting marshmallows at a bonfire. I had a patient who had an asthma attack, and she was an adult, and she was just roasting marshmallows because of the smoke from the bonfire.
Get
And
that. Okay.
so, how do we manage that? The whole goal is to remove yourself from that irritant. Now, that's kind of difficult. We can't tell you quit your job, right? If you're working at a factory or et cetera. So our goal is to reduce your exposure. That's usually wearing a protective gear like a mask to kind of create a barrier between yourself and the irritant. And then if you smoke, well, you should work with your primary care physician to cut out that smoking. It's easier said than done, but it's great for your health. So that's number one, chronic bronchitis. And usually that cough is productive, meaning a lot of patients will bring up mucus with that cough. The second common cause is medications. And the most common medication category is an ACE inhibitor, which the generic name or brand name is lisinopril, which treats blood pressure. So up to 20% of people who are put on an ACE inhibitor or lisinopril will have a cough. And that cough is usually a dry cough. That cough is common in women, in people of African descent or Black Americans and Asians. So when we put people on a blood pressure medication like lisinopril, we really have to make sure to tell people that if you start getting a cough, whether you start getting that cough in the beginning or months into the medication, to let your doctor know. Again, that's usually a dry cough, and the treatment is, well, if you need that blood pressure medication, we hate stopping it, but if we have to, we'll talk to your primary care physician, we talk to your cardiologist, and we switch out, that medication. So that's
I
number
know
two.
that. Yeah.
Yes, that's number two. And I'm going in the order in which I think about the causes. So
Gotcha.
when I see a patient, I go through these 5 causes in my head because these are the most common causes in that order.
Sure.
So the third is called upper airway cough syndrome. Like, what does that mean? Well, your upper airway includes your sinuses and your nose. And so everyone says, oh, I have sinus infection. My sinuses are bothering me. But like, what are your sinuses? I mean, honestly, like what is sinuses? So your sinuses are these hollow cavities in your head. And I'm going to point to where they are. So the frontal sinus is right here. The maxillary sinus is right here, and then your ethmoid sinuses are right in between your eyes on either side of the inside of your nose. That's your sinuses. Your sinuses are usually filled with air. They're usually filled with air. But when they get inflamed, when they get that itis, the inflammation, that sinusitis, they start filling with fluid. And when they fill with fluid, sometimes they can attract bacteria, sometimes. And so those sinuses will actually drain through your nose. So that's the first cause of upper airway cough syndrome. The second is the nose. And so there are 3 causes of kind of inflaming the nose. The first are allergies. That means trees, grass, weeds. I'm sorry, your dog or your cat. Death mite, cockroach. The second could be non-allergy symptoms. So non-allergy causes like humidity or fumes again. And the third, which actually happened to me, was after a viral infection. So you get a virus and the virus
Mm.
inflames your nose and then you just start dripping. And so
Yes,
whether
that
it's your,
drip. Oof.
yeah, it's the drip, it's the drip. And what a lot of patients will say is, Dr. Wolf, I feel like this liquid that's just dripping down my throat. And as soon as a patient says that to me, I think it's either your sinuses here, here, or it's got to be your nose that's causing this drip. And so what do? Well, if you are someone who is stuffy, running with change of the seasons, come to Wolf Allergy and Asthma Practice. I will test you for allergies. I'll skin test you to see if you are allergic. If those results are negative, then I may do a CT scan to see if maybe you do have some sinus inflammation. How do you treat it? Nasal sprays. There are a couple other treatments, but I'm not going to go into more detail. But that's the third cause. The fourth cause is adult onset asthma. Now, so many patients say to me, Dr. Wolf, I am too old to be diagnosed with asthma. There's no way my 40-year-old, 50-year-old, 60-year-old, 70-year-old self, yes, I had a 70-year-old say, you have
Wow.
asthma. That's a good thing, Dr. Wolf. How are you talking about I have asthma? I'm not wheezing. I don't have shortness of breath. How is it that I actually have asthma? And my response is, hey, you're a child forever. You can be diagnosed with asthma. And so some adults, some people don't have asthma symptoms until they get to adulthood. Somehow they've avoided every single asthma trigger. And then one day, bam. So for example, you could have a roommate, you moved into someone's place and they have a cat. Boom. Your allergies are triggered by that because the cat dander is triggering your asthma because of your allergies.
Where
Another
you
one,
where you could have, and this could be new onset, meaning, hey, I
new
was fine
onset.
around cats when I was little, but now,
Yep.
got it.
Yep, exactly. You could work at a factory or using cleaning products, and all of a sudden you start coughing. What's very common is a viral infection. I will have adults that will get a cold and they just keep coughing and coughing for like months on end. And what happened is that cold completely unmasked asthma in you. I mean, it like lifted the asthma veil and now you got it. And so what do? Well, we calm you down and say, it's okay, you have asthma, it's all right. We'll send you to get a pulmonary function test, which is where you blow into a tube. We see how your lungs are, and then we give you an inhaler. And if your cough gets better in like 4 to 6 weeks, you got asthma. If your cough doesn't get better in 4 to 6 weeks, we got to look at other causes. And so that cough is usually a dry cough. You're not bringing things up. It's just a dry cough. And sometimes it really bothers people at night as well. They'll really, really cough at night, but it can occur throughout the day. The last one is reflux. And so many patients say, well, Dr. Wolf, I don't have that sour taste in my mouth. I don't feel like I have my chest burning. I can eat chocolate. I can eat spicy food and I'm okay. That means I don't have reflux, right? My answer, no, you still can have reflux. I'm sorry. So you can actually have silent reflux. So there are two types of reflux. There's gastroesophageal reflux. This may get a little gross, but the contents in your stomach will reflux into your esophagus. That's the first reflux. The second reflux is the contents in your stomach reflux all the way into your pharynx, all the way up into your larynx, your voice box. So you can reflux like all the way up. And that will cause a cough. And a lot of patients, usually a dry cough, and a lot of patients will say, especially when I lie my head down, I try to take a nap or I go to bed and I start coughing. And as soon as they say that in my head, I think you may have acid reflux. So this is the last one we look at. Why? Because this is the one that takes the longest for us to see if it even is the reason. So I might put you on Prilosec, pantoprazole, and I tell you, look, I'm sorry, Dr. Millhouse, but 3 months, it may be 3 months until you see some change, and 6 to 8 months for it to actually go away. So that's the last one we look at. Now, it is possible that you could have a combination of these 5. You can have adult onset asthma and reflux, which by the way is very common. A lot of asthma patients have reflux. That's both adults and kids. You can have allergic rhinitis, allergy of the nose, and have adult onset asthma. So medicine is an art. It's an art that we practice. And so I work with my patients to kind of figure out what exactly is causing that cough. So for review, hopefully I didn't go too fast. The first one I look at is bronchitis. Do you smoke? Okay, well, that's where your cough is coming from. Or are you working in a factory, you're around chemical fumes, something like that. Number 2 would be medications. I always check a patient's medication list. Are you on lisinopril? Are you on a blood pressure medication? Oh, that may cause your cough. Why don't we talk to your primary care doctor, stop it, and see if your cough goes away. 3, upper airway cough syndrome. Is it your sinuses here and here and here, or is it your nose? Come to me, Wolf Allergy Asthma, I'll test you, okay? Number 4, reflux. Just because you don't feel the chest burning or you get the sour taste doesn't mean you don't have it. Yeah. So I will put you, I'm sorry, number 4 is adult onset asthma. My apologies, number 4. Number 4 is adult onset asthma. This is live, okay? So coughing, you got a virus, you kept coughing, or you moved in when someone's got a cat or you have some type of trigger. I put you on an inhaler, we see how you do. The 5th is reflux, okay? And so again, that's the last one. I'll put you on Prilosec and we'll see how you do. But also, we have to work together. There's something in medicine called shared decision making. Dr. Millhouse knows this. And so we kind of sit down together and talk about how we can help you solve this problem. And sometimes one of my solutions may not work. Maybe you don't have maybe it wasn't the blood pressure medication, you're still coughing, So we kind of, again, as art, and we work together. So those are the 5 causes of chronic cough. And now I will switch it off to our wonderful board certified urologist, Dr. Millhouse, to talk about pelvic floor disorders.
Yeah, and before I do that, I want anybody, please ask questions. You can put them in the question box. Somebody asked a question that we'll have Dr. Wolf talk about. It's a good question. But just put it in the question box if you can. But I'll go through this quickly. Pelvic floor disorders, we think about pelvic floor disorders as like pelvic floor weakness, and then there are a set of disorders that are more due to like pelvic floor dysfunction and tightness or high tone. And for the sake of what we're talking about today, it's not including those type of issues. Okay, so we're really focus on pelvic floor weakness disorders, all right? And when we think about that, we think about something called stress incontinence, which is one manifestation of pelvic floor weakness. Stress incontinence is I will expel urine unintentionally with any rise in abdominal pressure. And what happens is the pelvic floor doesn't support when we do things like, if me, I have a huge laugh. Like, I laugh so loud. When, hey, Carly, when I coughed just now, fortunately my pelvic floor is in okay shape. I don't leak out urine when I do these things, but in a lot of people, humans with vulvas and humans less so, but also can happen in humans with penises, there'll be a leakage. Okay. So they'll cough, leak urine, they'll laugh, leak urine, or they'll go. I have a lot of patients, women patients, that are like, yeah, I stopped running. I can't exercise. I can't heavy lift.
Mm.
All these things causes increased pressure in the abdomen, and our pelvic floor is supposed to support it, and it's too weak. It's a little weak or too weak, and it doesn't. So that's one manifestation. Another manifestation is pelvic organ prolapse. Pelvic organ prolapse is actually a hernia that
Oh
is
my
going through the vulva. So this is only for humans with vulvas, but it goes through the vulva of the vagina, or going it through the vagina. So basically you have organs that are supposed to be up inside of you, your uterus, your bladder, your rectum, your intestines. But if these are herniating outside and coming towards the outside and through the vulva, that is called a prolapse. And most patients will explain that they feel like they have a bulge hanging out of their vagina. I've had a patient, I love the way she put it. She was like, yeah, I feel like I became a dude and I've grown a scrotum,
Oh my
because
gosh.
she had, yeah, yep. Some patients will say it feels like a tampon that's not quite in. If you're a human with the vulva
Mm.
and you've had a tampon ever, you know exactly what that feels like. It does not feel, it's not painful, but it sure doesn't feel fun.
Right, right.
Um, yes, these can be cystocils and rectocils. That just is kind of more terms to define. Is it bladder or is it rectum that's prolapsing? But pelvic organ prolapse encompasses anything that could be prolapsing through. Sometimes it's even in patients who've had their uterus removed, you can still have pelvic organ prolapse. You can have the actual top of the vagina
Oh,
come, because the actual top of the vagina can still come inside out. I liken it to like a sleeve or a sock that's like just inside out. So the
oh my
top of the
gosh.
vagina is supposed to be in, but it's come out, and you see that. Okay. Again, this is not usually painful, but it's uncomfortable. Sometimes
Yeah.
it's so bad. I've seen patients where it's so bad that they cannot pee. I had a patient who had to use a catheter because it blocked her opening of the urethra because of this big bulge in the way. In the most extreme version of that, it blocks the opening, and the patient can't pee, and then therefore it backs up into their kidneys, and so they have kidney failure. This is
Oh my
rare,
God.
super rare. Usually pelvic organ prolapse doesn't get that bad, but
Yeah.
that can happen as a consequence. And so those are the main two manifestations of pelvic floor weakness that we
Mhm.
see. The leakage, primarily the stress incontinence leakage, because there is another type of leakage called overactive bladder, which is more about your bladder being too overactive than your pelvic floor. Um, but the stress incontinence is all about the pelvic floor, and then organ prolapse. And the main causes of pelvic, or risk factors, I should say, for pelvic floor weakness. Number one, childbearing, pregnancy and child delivery puts strain and weight on the pelvic floor. Carrying, um, a, you know, a child for 10 months. It's not 9 months, by the way. It's 10 months, 40 weeks, 10 months. They don't tell
Oh,
you that. You be thinking it's 9 months, and then you realize, no, 40 weeks is 10 months. Okay. But anyway,
wow.
um, carrying that's a lot of weight, in a short amount of time. And then, childbirth. Vaginal delivery is
Mm.
a little more strain on the pelvic floor than C-section, but C-section is not 100% protective. Um,
Wow.
Gaining weight, period. So the more, it's about force. The higher the weight, the more the force of that is seen on the pelvic floor. Um, the other thing is age. Just getting older, our pelvic floors get weak. Okay, so we tend to see these things that are more prevalent in older patients, but not exclusive to older patients. Is what I'm trying to say. And
Hmm.
chronic cough. is a very common risk factor for pelvic floor disorder, pelvic floor weakness. And imagine every time you cough, your pelvic
Yes.
floor has to be engaged because
Yes.
that's what's supposed to happen, because we would all be leaking on ourselves if we didn't
Right.
have our pelvic floor engaged when we cough.
Right.
Okay.
Yeah.
And so every time we do that, our pelvic floor is engaged. Well, if your pelvic floor is doing that every day,
Yes.
multiple times a
Yes.
day, it's doing that. It's not going to sustain itself for long.
Yes.
So
Yes.
chronic cough, I find that,
Yes.
which goes hand in hand with smoking. I think the risk factor with smoking and um, uh, pelvic weakness might be more about the cough than about, like, the nicotine, if you will. You see what
Yes.
I'm saying?
That's a good
Um,
point.
uh, yep, absolutely. So those are the main causes that we think about.
Yeah, I mean, that's such a good point that again, if you're coughing and I've had patients that are, I mean, bad, I can just think of this one patient I had. It was a female patient and she coughed. I mean, it was just nonstop. And she was older and, you know, I, I don't know if she didn't tell me about any urine incontinence but I would not be surprised
Oh,
by
totally.
the like the ferociousness of her cough. She was coughing in the room, how bad it was. And so the quality of life is not only the cough itself, because especially in the era of COVID, nobody wants to cough. Nobody wants to cough with COVID because you essentially are wearing a scarlet letter, right? I mean,
Yeah,
you cough,
yeah,
it's like everybody's
yeah.
just whoop, woof.
Yep, yeah.
So that in itself is difficult, just in the time that we're living in. But also, if you're also having the urinary incontinence, that
Oh,
could just make
yes.
the issue even worse. So it's like not only am I coughing, but now I'm
I'm
right. So
pissing on myself. No, and
myself.
oh my God, I've seen patients who it can be so severe, like they're blowing through their pads and onto
Yeah.
their clothing because of how much the
Yeah.
leakages. When I examine patients, so this is mostly my work is mostly diagnosed by history and exam,
Right.
and
Hmm.
so I will examine patients and I'll try to tell them to hold their urine. I don't want them to have just peed. And I will have them
Hmm.
cough in my presence. I'll have them cough in stirrups lying down, or I'll have them cough standing up. And in some cases, I've learned the hard way. Urine is a hazard. It's a professional hazard. Okay, that's why I always wear scrubs. But in my early days of starting, I'd be like, okay, I'm examining you now, cough, and like I got urine on me, and I always tell the patient, please don't feel bad. Like, this is my
Right.
job.
Right. Right.
This is what I'm no, they're apologetic and they're kind of like
Right.
getting upset. I'm like, please, please, please don't get upset. But
Right.
now I stand to the side. I'm like, okay, you know. But yeah, it can be devastating as far as for the quality of life. I mean, can you guys
Yeah.
imagine coughing all the time?
Time. Yeah.
Trying to like be in a conference and you're coughing, trying to
Right.
like be amongst friends and you're coughing, and then
Yeah.
add that to like now you're leaking from the other end. Yeah,
Right.
not
So
fun.
Dr. Mel has so when I have patients, that do present to me with chronic cough, men and women, if they're too embarrassed to say they're having incontinence, do I just ask them, by chance, are you also having incontinence too? Is there a way I can broach that as well if they don't, because they're coming to me and you're just going to deal with this cough. Like, you're not going to deal with anything
Yeah,
else.
yeah,
I'm not
yeah,
going to tell you anything else. So how should
yeah,
I?
yeah. I think so just one thing about like, hey, you're just here to do this. Why are you even thinking about that? But I think in our
Right.
medicine isn't just one thing. We have to realize there are things that are connected,
Right.
and we hope to be holistic type of providers or physicians,
Right.
I should
Right.
say. One area, for instance, and I'll answer your question, I promise,
No,
is
no.
that like when I see my male patients or my humans with penises and they're like, oh, I have difficulties with erections, well, best believe I'm asking about their heart and if they have diabetes, and do they smoke, and do you
Right.
have a primary care physician, and how do you take care. I'm asking about their whole cardiovascular health because I recognize the link between erections and difficulties with erections and your heart.
Right.
So anyway, what I would say to you is, first off, I think you make it easy you make it easier for them to feel like they can respond by saying, chronic cough is a very known risk factor for some pelvic floor issues. It's
Yeah.
very common. And so you kind of not normalize it, but you destigmatize it, and you say it's very common that patients who have chronic cough may also inadvertently leak urine, when they cough. Is that something that you've
Yeah.
experienced ever or often? And
Good.
I would imagine and you have such a nice demeanor too. Like I imagine most
Oh,
of your
you're so
patients would
nice.
answer honestly and be like, yeah, actually, if they do, like, yeah, I do. And it, really sucks. Can you advise me who
Yeah.
do I
Okay.
see? But yeah,
Okay. Yeah. Thank you for that. I really
yeah,
appreciate that because I was kind of wondering how do you broach that? But yes, yes, that's good.
yeah. I always try to like let patients know, like, by the way, you are not alone. Like literally, I probably,
Right.
you are in good company. And I sometimes will use myself as an example. Like, yeah,
Mhm.
one day when my bladder was really, really, really full, I coughed and, a little bit came out. I was like, what is that? I'm not afraid to use
Mhm.
myself as an example. And that usually helps. But yeah.
Yeah. No, I had a chronic cough so bad. I'll never forget. I had a chronic cough, and it was horrible. I was seeing patients, but it was just ongoing, ongoing. And I was telling these patients, I actually like vomited. I mean, that's how
Wow.
strong the cough
Wow.
was.
Wow.
When you get to that
Yeah.
cough, and I actually was prescribed steroids, and it took the cough away. And although my primary care did say, look, if this happens again, we need to give you a pulmonary function test because Dr. Wolf, you may have asthma. So,
Were
and the
you
cough went.
where were you in your training when you had this?
I was actually at Cleveland Clinic,
Okay.
and I was at Cleveland Clinic, and I was seeing patients, and I was coughing, 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 coughing. I could not believe. Never in my life had I coughed, and it was just all the time, all the time, all the
Yeah.
time. And I was an internal medicine resident. I wasn't an allergy immunology, so I'm thinking, what is this?
Did you
Because
know you
it
wanted to do that, or do you think that motivated you to do that? That experience?
actually Actually, my first exposure was angioedema, which is a big word for swelling of the lips. My first week of intern year, my first week of being called Dr. Wolf, which we never even really responded to, I ended
Yeah,
up
you're
in
like,
the
who
I
is that?
ended up exactly. I ended up in the ER. So I went to bed and I woke up in the middle of the night and my lip was a little swollen. It was painful. And I said, okay, whatever. I go back to bed. I wake up again and my lip is bigger. And I call my chief. For those who don't know, the chief is a person who's
The
graduated
boss.
and they're
Yeah.
the bosses, whatever. They're the official doctor. They are in control of all the residents. I called her and I said, I think my lip is swelling, but I'm just going to go to bed. Like, I'm not going to. She said, you need to go to the ER now. I said, no, I don't. She said, you need to go to the ER now. And here I am talking to her. My voice is getting a little muffled because now my lips are getting larger.
Yeah.
I went to, yeah, exactly. And I wasn't going to deal with it. I was going to sleep again. I mean,
We do that. We do that to
you
ourselves
see,
too much.
yeah, you see, for those who are on the line, you see the dedication of doctors. We're going to come to work with our lips swollen,
Yeah,
you
we
know.
will. Yeah.
Anyway, so I ended up in the ER and they gave me some steroids, not through the IV, but they gave me some oral steroids and some Benadryl. And they said, you need to see an allergist. And I saw the allergist at Akron Children's Hospital and he said, well, tell me what happened. I said, well, I had some chicken and some banana. Could I be allergic to chicken and banana? And he's like, you're not allergic to chicken and banana, but I'll test you for
Yeah.
chicken and banana. So he tested me. Obviously, I wasn't allergic. He said, you just had angioedema, and 30% of Americans will have hives or swelling at some part of your life, and it just happened to you. He said, look,
Wow.
come shadow with me for a month and you'll see. I saw a 30-year-old guy who had a scrotum that swole as big as like an apple and a tomato.
Okay. Oh,
And
that ain't
he
that
had
big.
angioedema. Oh, see, see, that was big to
Try a
me because
cantaloupe.
yeah, oh, okay, no, it wasn't
Yeah.
that big. But I saw him and he was like, what the heck is this? I'm a young, healthy guy. And all of a sudden, my scrotum is swelling. I told
Sure.
him, like Dr. What's his name told me. He said it happens to 30% of Americans. I'm sure it wasn't what you ate. Happened to me. So
Yeah.
anyway, that got me interested in allergy immunology, and here we are.
That's
So
great.
anyway,
It's
but
it's
yeah,
great that there's a lot of parallels here. I mean, you experienced something that kind of triggered your line of choice. And like for me, I loved
Yeah,
urology.
what's
I
it
met a
for
black woman
you?
who's urologist that like blew my mind. But
Yeah, they're
I
not many
also
female
suffer from
urologists.
overact. Yeah, I know. I didn't even know they exist. I
Mhm.
was like, what is this? Like I was just
Yeah.
so um amazed. But then I also suffer from overactive bladder too, which means like when
Mm,
I gotta go now. And I've done
right.
this has been something I've suffered all my life. And so I feel like I very much can relate to patients who have urinary issues and control issues myself. So, and it
Yeah.
feels, urology feels like home. I want to say hi
Oh,
to a couple people and then we
good.
should take some questions. First of all,
Yeah.
my Orange Theory Frankfurt has joined us. I'm just so geeked that the place that I, work out twice a week is come to listen to little old me. So thanks for joining. And then there's Eddie. Thank you. I see you. Oxytocin. That's such a cute name. There was Myrna, I believe. She's such a great supporter. So thank you all. But
And
anyway,
Dr.
let's get to
Millhouse,
some.
we're getting a lot of hearts. We got a
Yes, we
lot of hearts.
are. They love us.
Yeah. Okay.
As we should. So we got some questions. Okay. Okay.
Okay.
So the first question we got was, and I don't know if you can do this.
Okay, let
Can
me
you look in the
see.
question box and then you can show the question?
Yes. Everyone tap. Oh, I tap it?
Yeah, you tap the
Yes.
question box. There you go. Well, that was
Okay.
the second question, but you can answer that. Okay, or what is this? Clinically, is there a way to define the prolapsed organ? I had an elderly patient, known hysterectomy, that had a urinary incontinence on exam. I was able to see an organ come out of the vagina when she bared down. Yeah, that's a great question. So on exam, everybody always assumes the bulge is like cystocele or rectal seal. And honestly, you need to know how to do the speculum exam to know where it's coming from. The bulge can be misleading and you may not know where the organ is coming from. And this just takes a little bit of training. That's why I'll be honest, whenever like a non urogyne or female pelvic specialist sends me a prolapse and they're like, yeah, it's the bladder that's prolapsing or the uterus. I'm always like, okay, thanks. I'll be the judge. And I would say over 50% of cystoceles are not, which is the bladder prolapsing, aren't just cystoceles. The other thing is that prolapse can be more than one organ. It's
Oh,
not
wow.
just, and a lot of times it is more than one organ. I would say more than 50%
Like
of the time.
what? What are the
It,
organs
so
besides?
the bladder,
Yeah.
the uterus or the apex of the vagina in somebody who's had a hysterectomy, right? If you have a
Okay.
hysterectomy, you have no uterus, but the top, when they take that hysterectomy out, you could still have that top of the vagina, what we call the apex, which is
Oh,
supposed to be
okay.
the deepest in, could be prolapsing. You can, behind that, you could have what we call an enterocele. Enterocele is intestines. So the actual small intestines can be prolapsing. The rectum could be prolapsing. So, and you can have a combination of these things. So, we take the
Wow.
speculum and I'll take the speculum apart and I'll like go above and below. I do a lot of maneuvers with the speculum to see. It's not just a quick little, speculum exam. It's a lot of maneuvers. You can ask my patients. I'll sometimes have them stand up and I will get on my hands and knees underneath them and like look because that gravity makes it more pronounced. And I will tell them, this may be weird to you, but this is just a regular day in the office to me. And I'm literally under them, under their crotch and making them bear down. But it
So
helps
Dr.
me
Millhouse, you're
tremendously.
like Neo in Matrix, just like, you know,
Yeah, I know when I
with
get
your
too old to like
speculum.
get down and do that,
Yeah.
maybe then it'll be time to retire. Yes. Good question.
Okay. Great question. Okay. Now I will tap the first one you put. Okay.
Yeah.
Oh, what happened to it? Okay, here it is. What explains the correlation of adult onset asthma and silent reflux, I think is what it was
Reflux. Yeah.
saying. Yeah, silent
Yes.
reflux. So, it's interesting because what we find is that there is an association between asthma and those with reflux. And it's kind of really not a known association. It's just kind of an interesting kind of correlation we found. Now, what I will say with the cough and silent reflux is that silent reflux could be that cough. That cough may not necessarily is not also sorry. That cough is not also asthma, but that cough could be due to that silent reflux. But again, we don't really know like the mechanism between asthma and reflux. It just so happens that there are patients that have the two. Now, with asthma associated with obesity, because there is an obesity associated asthma, we do see reflux more common in that group. But in general, the real mechanism is not really known between kind of asthma and reflux.
Okay, good question.
Hopefully that answered it. I know it was not the best answer, but I tried.
Well,
Okay.
sometimes, yeah,
Um, is chronic coughing okay?
yeah, always.
Von,
That's a good question.
yeah, is chronic coughing always treatable? Yes. Most of the time, I would say 95% of the time it is. Now, the question is it going to go away, like completely go away, or can we get it reduced to a level that is tolerable to you? It can be both ways. There are people that they have coughed so much for so long, they have something called habit cough. So it's a reflux at this point. When I say a reflex, I meant to say a reflex. So when your doctor hits your knee and your knee raises, that's the patellar reflex, the knee reflex. Your cough now is a reflex. Your body is so used to it that it's just a reflex cough now, a habit cough. And so with coughs like that, we look at the neurons that are innervating your throat, and we target those. And sometimes we can't make it go completely away, but we can reduce that cough frequency down for you to have a better quality of life. So it's definitely treatable, definitely manageable.
Yeah, I do. My sister-in-law had a chronic cough. I don't know what kind of testing and stuff she went through. I've
Mhm.
had I've had I've had a couple of people I know in my life with coughs, and some of the stuff that has been used on them include Botox injections,
Yeah,
which use Botox in the bladder for overactive bladder, so I totally
yeah,
understand that mechanism. It's a basically a temporary muscle paralytic, and so
ex-
um,
exactly.
by paralyzing, I don't know where you guys inject it. Where is it injected for cough?
So that, to be honest, that is more the ear, nose, throat doctors that
Yes.
do that.
Yeah.
But it is at this point when your cough gets to the point in which, number one, you're not a smoker. Number two, it's not the medication, it's not upper airway, it's not reflux. Um, and it's not adult onset asthma. That's when we get to looking at the neurons, and we will
No.
give you
Okay.
medications like gabapentin, that will attack kind of the neurons, Botox as well. And when it gets to that point, I, as an allergist immunologist, will refer you to an ear, nose, throat doctor or a person who specializes in kind of chronic cough and the advanced treatments.
Got
Yes.
it. Understand. And somebody mentioned the lisinopril. They're like, hey, they came in late, and I'm just typing that. Yes, Dr. Wolf did a beautiful job educating us about the ACE inhibitors and the cough um,
Yeah.
correlation. So that was new. I may have learned that in medical school, but I mean, who remembers medical school? So
Yeah, exactly. Exactly. Yeah. So there is a substance in your body called bradykinin, and I'm not going to go
yeah,
into much detail because I'm not going to bore everyone that's on this live. But there is a molecule called bradykinin, and when it's released, it irritates the airways and causes you to cough. Well, with ACE inhibitors, they actually increase the amount of bradykinin in the body, and so therefore, when you take an ACE inhibitor, you have more bradykinin, you have more cough, and that is why ACE inhibitors can lead to cough in up to 20% of the population.
great. Look at all this knowledge. I want to shout out to Dr. Uchi Blackstock in the house. Thank you. And Chauncey, my friend Chauncey, who's in the house. and everybody else, obviously, too.
You got a great question that
These
I'm
are.
going to, um, I see it, but oh, yes. Is
Oh,
there a
I can read
standard
it if you need.
approach?
Yeah,
Oh, I see it.
got
Is
it.
there a standard approach to rule out lung cancer in a patient with chronic cough and active smoking? Yes, exactly. So when I get a patient who is a smoker and they have a chronic cough, the first thing I do is get a chest x-ray. I don't move to the CT yet. I get a chest X-ray. I take a look at that chest X-ray to see if I see anything, there. Obviously, you ask for other signs for malignancy, which is our big word for cancer. Have you lost weight? Do you have night sweats? Questions like that. And when I ask about weight loss, because patients say, if I could have $1 for every time someone said, well, I don't lose weight, but I've gained it, I would be a billionaire, right? I mean, everybody responds with that one. But what I will say is, are your pants fitting a little looser? Have you gone down a belt size? That is weight loss. Okay. So I ask those type of questions. You put that clinical history together and you get a chest x-ray for sure. If I have a smoker that's been coughing for 4 to 6 weeks, I get a chest x-ray immediately. And from that point, I go from there. Great question.
We have another question.
We have a lot of questions. That's
Yes,
good.
I know.
But I don't see the new one.
The question is with Yvonne Gilead. Yvonne Gilead, sorry. I'll just read it. The
Oh,
most
oh, I see.
common,
Mm-hmm.
yeah, yeah. What is the most common treatment for overactive bladder? Most common treatment starts off with behavioral changes and with or without medication. So, what are behavioral changes? Well, that means ditching a lot of the bladder irritants that we have come to just accept and include in our food and drink. So that's the coffees, the teas, the sodas. I used to be an avid coffee drinker, and in residency, I literally couldn't drink coffee and still be like a busy resident. I was in the bathroom all the time, so I had to give it up. So, um, alcohol as well. I tell my patients, listen, I think starting small, Rome wasn't built in a day. Especially as if the more the habit is like, oh, I drink, 2 pots of coffee a day. Like, okay, well, we're gonna have 2 baby steps here. So that's one behavioral change. Another behavioral change is that we can institute is timed voiding. So where you kind of go on time. So some overactive bladder patients don't go frequently, but when they do have to go, they got to go urgently. So there's a difference. Like they may not go frequently, but they barely have any time to get there before they're already having an accident. So you can kind of go on time and be like, I'm just going to go to the bathroom every, 2-3 hours, regardless of how I feel. Another behavioral change is using your Kegel muscles. And I talk about this on my Instagram. There's something called urge suppression. Urge suppression Kegels are where you do Kegels quickly and rapidly. So everybody's learned, oh, do a Kegel and hold it as long as you can. And that's not really how we like to teach people. We don't want to overstimulate the muscle. There is a purpose for Kegels. We want to make sure we're doing it appropriately and not overdoing it. And for urge or overactive bladder, which main thing is urgency and reducing that, is you do quick, repetitive, off and on Kegels. So off, squeeze, relax, squeeze, relax, squeeze, relax, multiple times. And you do that at the onset of urgency. So suddenly if I had to pee right now, what I would be doing would be to doing a bunch of quick Kegels. And that can kind of slow the bladder down or like decrease that urgency. I tell my patients, it's like muting your bladder. You just want to mute that. Be like, okay, let me get through the rest of this live. I only got 5 more minutes, okay? And then you can go. And then we may prescribe, there are a host of overactive bladder medications that we can try. Generally, if we do that, I tell patients give it at least 4 to 6 weeks. Beyond medications, I mentioned Botox. Botox injections in the bladder is very commonly used. There's something called sacral neuromodulation, which is basically we are taking the nerves, primarily in like your tailbone area, if you will, your sacrum. And this is not neurosurgery. This is not major surgery. This is minor or percutaneous surgery. But we can stimulate a nerve, which helps to control the bladder. And we can actually normalize the bladder, decreasing urgency and frequency. It's super cool. That is a device that's implanted inside the body. It's again not major surgery, but we can do that. We can stimulate a nerve in your ankle, and that nerve in your ankle
In
actually
your
is a feed.
ankle.
Yes, yep, is a feedback, or not a feedback, but it's a branch of the nerve in your sacrum. And by stimulating that nerve in your ankle, we can normalize the bladder.
I'm
So these are
trying
things that
where is this nerve in the ankle that,
it's called the posterior tibial nerve. It's on the inner
yeah,
on the inner part of your ankle near the
right,
medial
right.
malleolus. Oh,
Yeah.
girl, I'm like screwing up the word, but you know what I'm talking.
Yeah, I know what
Malleolus,
you're talking
medial
about.
malleolus.
Yeah.
It's near. It's near here. This part of your ankle. I don't know if you can even see it, but like
Yeah,
that part of your ankle, that
yeah.
little
Yeah.
part. Yeah, there's a nerve right there. So, so we can stimulate that nerve, and there's all malleolus. Thank you, somebody,
Well,
for
go
helping
ahead,
me with the
Dr.
spelling.
Millhouse. Go ahead, Dr. Millhouse.
Malleolus. Yeah, I'm a first stall. Thank you so much. So yeah, there's a lot of treatments. A lot of people don't know about all the treatments that I just described. They just think, you know, meds maybe at the most, but there are definitely, and these are all FDA approved.
Wow.
Yes.
Now that
So
was
we got like
interesting.
5 minutes. I want to
Okay.
make sure that people know where to find you, follow you, all that good stuff.
Yes. So you can follow Wolf Allergy Wolf Allergy is my Instagram. That's two F's. You can also go to wolfallergy.com to find out more about me and my practice, Wolf Allergy and Asthma in Detroit, Michigan. And I'm Wolf
Awesome.
Allergy on Facebook and Twitter as well. And Dr. Millhouse?
And yeah, so if you're in the Midwest, even do you do like a telemedicine?
Not outside state. I do
Okay,
telemedicine within, yeah,
the
but not
state.
outside Michigan. Not yet. Not yet.
Okay, so in-state Michigan telemedicine even, but certainly if you're in the Midwest, Wolf Allergy, she's her own boss, her own practice. That's huge. And I am at Dr. Millhouse on Instagram. That's Millhouse with one L, not two L's. And I am on TikTok at Your Favorite Urologist. And I have my website coming out very soon, which will be www.yourfavoriteurologist.com. So just remember Your Favorite Urologist, and you won't go wrong. Um, you'll find me some kind of way. And yeah, I do telemedicine. So I am happy, and I have done telemedicine out of state, and I am
Okay.
happy to connect with people who need a specialist, a urologist. So
Perfect.
yes.
Well, thank you so much, Dr.
Yeah, thanks.
Millhouse,
This has been
for
fun.
doing this Instagram Live with me. And thank you for all the people who joined us today and
Thank
sent in
you.
fantastic questions. This was fun.
Thank you. Thank
Yeah.
you.